I'm Dr. Vijay Jain. I'm Professor of Orthopaedics at RML Hospital, New Delhi. So, in the beginning, I would like to say thanks to DGHS for involving me for making these standard treatment workflow guidelines for musculoskeletal disorder. I was in the review editorial board, and I'm also thankful to the Dr. Gauri, DG of this institution. And now my topic is the orientation of the musculoskeletal disorder. So basically, it is a modern perspective. You are from the Siddha practitioners. So why we have chosen these 6 or 7 diseases? Because they are chronic, they are disabling, they cause a lot of morbidity, and not only that, the treatment is very variable among specialties. So there is no permanent cure. So because of that, we just chose these particular problems, because we need holistic treatment. We need treatment from the various specialties of medicine to treat certain conditions, right? So I will take all one by one. So the first is osteoarthritis. So what is osteoarthritis? Everybody knows. It is a degenerative conditions and involves the articular cartilage. It can usually occurs in the elderly, but nowadays the younger patients or the middle-aged patients or individuals are also involved. Obesity is one of the common factor which can cause, but there are several other factors like congenital problems, certain congenital abnormalities in the knee, or some traumatic issues in the past with the patients over the knee, and then metabolic, like some storage disease like hemochromatosis, also some neurological problems like Charcot disease. I think you must be aware of all those terms. Okay. And then some vascular problems and bone related like avascular necrosis. All these problems can cause. So we can divide the osteoarthritis into primary, which is because of the aging, or secondary. Then it can involve any joint. Mostly the weight bearing joints are involved, like knee, hip, spine. The shoulder joint can also be involved, and then the axial skeleton like spine, cervical spine, and the lumbar spine can also be involved. So these are the risk factors. Some of them I have already discussed, and also there is because of the poor bone mineral density, osteoarthritis can occur. So according to the American College of Rheumatology, there are certain guidelines to diagnose knee, hip, and hand osteoarthritis. This is very well published. Everywhere you can see, and based on this we can make diagnosis. So I will just discuss among all the diseases when we should suspect, what are the investigations which are essential to make a diagnosis, and then when to refer these patients, because it may not be possible for you, for me, or other specialty, subspecialty to treat patients. Then we have to refer them. Those are red flags, right? So whenever we have to look for the pain, we have to look for what is the nature of pain, and then what is the severity. It is variable, because some may have mild pain, some may have severe pain because of the amount of degeneration in the joint. So it can varies, and then patient may have stiffness, which is short lasting, not like rheumatoid arthritis, where the stiffness lasts for more than 30 minutes. So stiffness may be there, or maybe there may be a bony enlargements. Then there may be deformity, and because of the pain, patient may have fatigue, sleep disturbances, depression. They have reduced activity of daily living, not able to squat, not able to walk properly, not able to jog, or not able to climb the stairs. So certain activity of daily livings are affected, right? If you examine those patients, then you may get some joint line tenderness, there may be some swelling, reduced motions, there may be some crepitus. When you move the joint, some sounds will come out from the joint. So these are called as crepitus. And then patient may have some deformity which varies from varus deformities to the valgus deformities, or flexion, fixed flexion, or recurvatum deformities. So deformities can vary from patients to patients. Also, if you see the hand osteoarthritis, the distal interphalangeal joint DIP, which is involved. So the diagnosis usually requires a plain X-ray, which is the must, and it should be the weight bearing for the weight bearing joints. For example, for knee, we have to advise for the X-ray both knee AP lateral, AP in standing. So weight bearing X-rays are required, both AP and lateral views, and then certainly some other views are also required in certain patients in order to diagnose the tricompartmental osteoarthritis. So we have to remember that there is no role of joint aspiration, MRI and CT scan. So diagnosis is purely based on the clinical findings and on the X-rays. And there is a one grading called as the KL grading, where we can see for the joint space narrowing, and depending upon the joint space narrowing and presence of the osteophytes, one can easily diagnose whether the patient is case of stage 0, 1, 2, 3, 4 or mild to moderate to severe osteoarthritis. So we have to look for the certain differential diagnosis, because the diagnosis is clinical, so we have to exclude certain diagnoses, and these are some of the diagnoses. For example, rheumatoid arthritis, some bursitis, some infective arthritis, post-infective arthritis, gouty arthritis, because patient may have only one joint is involved, or right or left knee, so we have to exclude whether he or she is a case of a gout and a neuropathic joints. Treatment, just little bit. First of all, as I said, MRI is not at all required, and we should not use opioids in these cases, and we should also avoid use of nutraceuticals and intra-articular steroids, as well as the hyaluronic acid, because they have very limited roles. So in my practice, I usually start with the exercises, weight reduction, lifestyle modification, and sometimes the analgesic may be required in certain patients. So this is how we treat patients from mild. We advise for the simple analgesic, topical agents, lifestyle modification, and for the severe cases, patient has to undergo for joint replacement, total hip or total knee arthroplasty. So what are the red flags? When to refer those patients? If patient have sudden onset of severe pain, there's a buckling of knee, patients may have some instability of the knee while walking, and then there may be some swelling or warmth, there's a history of locking or persistent pain, and patient is not relieved even after the surgery. So in those patients, we have to refer. So this is, I think, all about the osteoarthritis. Now coming to the rheumatoid arthritis, usually female gender is involved. It's a genetic factor, it's a synovial disease, and the synovial get hypertrophied because of some genetic predisposition as well as some abnormal immune response. And this inflamed synovium erodes the cartilages and causes the arthritis. So it is very painful, usually symmetrical, and it is a progressive, disabling, and also it also involves the multi-systems. Many systems, not only the musculoskeletal system, other systems like heart, lung, vessels, nerves, anything can be involved. So patients usually have pain, swelling, and stiffness of the synovial joint, and which often worsen during the morning or after a period of rest. And this stiffness lasts for more than 30 minutes. So usually any joint is involved, but the small joints of hand, small joint of feet, and then also the large joints are also involved. Sometimes it may be a monoarticular picture, only one joint is involved. We call it as a monoarticular rheumatoid arthritis. And in those cases, we have to exclude several other things. And also there is a presence of certain immunoglobulin antibodies like rheumatoid factor, which can be present in Other conditions also, normally it is present in about 70 to 80% patients, but like in Sjogren's syndrome, in sarcoidosis, in SLE, in tuberculosis, the rheumatoid factor can be positive. So it is not specific, but it has a prognostic value. If the value of the rheumatoid factor is high, then definitely it correlates with the severity of the rheumatoid arthritis. So not only this, some patients have fatigue, subcutaneous nodules, lung involvement, pericarditis, peripheral neuropathy, vasculitis, and hematological abnormalities. So if you can see, there's small joints of the hand and wrist are involved, and in initial stages only the joint swelling is present, but as the disease progresses and if patient has not taken any treatment, then sooner or later, because of the joint effusion, there is a subluxation of the joint or destruction of the joint, patient develop multiple deformities. And also sometimes the soft tissues are also involved, and in that case the tendon ruptures can occur. As you can see in the last image, there is a drop of the fingers, which is because of the tendon rupture. So the diagnosis can be made in a preclinical stage when there is only small joint swelling is present, or in a later stage when the whole joint is destroyed. So these are the four clinical stages: early arthritis, advanced arthritis, and a stage of synovitis, and the preclinical stage. So ACR, again, ACR has a diagnostic criteria when has to look for whether the large or small joints are involved, and accordingly one can score. Or if there is a presence of positive rheumatoid factor and anti-CCP. Anti-CCP is another antibody which is present. One more antibody, anti-fragilin, is also present, but anti-CCP is more specific for the rheumatoid arthritis, and if it is present, one can easily say that yes, it is a rheumatoid. So presence or absence of rheumatoid factor and anti-CCP, and whether the durations are less than 6 weeks or more than 6 weeks, and then presence of some acute phase reactant like ESR and CRP. And based on those guidelines, based on those mark scoring, one can easily diagnose. Also, the presence of radiographic erosions and subcutaneous nodule will always favor the diagnosis of rheumatoid arthritis. So when to suspect? Any patient with joint swelling, loss of mobility, proximal joints, involvement of the proximal joints, early morning stiffness which is lasting for more than 30 minutes, and then which eases with the physical activities, or there's a history of muscle pain, tiredness, some weight loss, generalized lack of well-being. On examination, one can palpate the joint. There may be tenderness. There may be some bogey kind of swelling because of the synovial membrane enlargement. So one can palpate the synovium which is hypertrophied and inflamed. And then there may be some redness, loss of joint motions. In most of the rheumatoid arthritis, the cervical spine is involved, because the C1, C2 is a synovial joint where articulation is a synovial joint. So the presence of the cervical spine should be ruled out, because in most of those cases there is a subluxation of the joint and can cause problems to the cord. Also, the deformities which can develop later on. So if you can see these three pictures, in one on the left side, there's a involvement of the metacarpopharyngeal joint and the proximal interpharyngeal joint, which is a case of rheumatoid. Another picture shows the osteoarthritis, and the image which is down, asymmetric presentation suggestive of gouty arthritis. So we have to use our clinical suspicion and examination to make a diagnosis. So certain deformities can be present, like ulnar deformity, ulnar drift of the hand, Botnet's deformity, Z deformity, swan neck deformity. These are other deformities which are present, but if you see those patients, you have to refer those patients, because deformity requires some surgical corrections. Also in the foot, one can see the claw toe, hammer toe, and then maybe some rheumatoid nodules or the valgus deformity of the hallux. So diagnosis, as I said, rheumatoid factor is the main, or we can do anti-CCP and CRP and ISR. Also X-ray, you can see the presence of the joint erosion, periosteocular osteopenia, soft tissue swellings, and juxta-articular osteoporosis. These are the certain clinical certain radiographic features which can be suggestive of rheumatoid arthritis. But there is no role of MRI, CT scan, ultrasound, right? So differential again, like the differential of osteoarthritis, in rheumatoid, the differential is osteoarthritis, presence of psoriatic and Sjogren syndromes, septic arthritis. Because the multiple sites are involved, one has to exclude the fibromyalgia, viral arthritis as well. Red flag, if any of the symptoms is pronounced, like more pain, more swelling, more deformity, more loss of function, elevated markers, more fatigue, patient is not able to do any activity of daily living, some neurological involvement like carpal tunnel syndrome, numbness, tingling and numbness, and extra-articular manifestation, one has to refer these patients to the other specialty for the further management. Now coming on to the cervical spondylosis, basically it's a degenerative, it's just like a osteoarthritis. So it's a degenerative conditions. It is also because of the degenerative disease, and there's a vertebral osteophytosis. Age is the important factor for development of the cervical spondylosis, and usually C5, C6, C6, C7 segments are involved, and this is characterized by the postural deviation, restriction of the neck movement, and there will be pain, there will be loss of lordosis, there will be reduced mobility, and if you see the X-rays, there will be a decrease in the spinal canal diameter. So one has to evaluate these patients with a neurological examination by doing motor, sensory and reflexes to exclude whether these patients are associated with any radiculopathy or myelopathy. So when to suspect? Usually in majority of patients the disease is asymptomatic. We all can have cervical spondylitis at present, but they are asymptomatic, but it can have certain symptoms also. So it usually presents after 40 years of age, presented with the axial back pain and stiffness, sometimes radiating pain because of the impingement of osteophytes to the existing nerve. Then there may be some altered dermatomal sensations and even myelopathy. So any problem can occur. The cervical spondylitis is a very, very, very slow onset disease, very insidious onset, and they have periods of more pain and exacerbation of pain and remissions. So these can be there. So also we have to look for the neuropathic and myelopathic symptoms. If there is a radiculopathy, patient will have pain, shooting pain, numbness, or the weakness of the existing and the segment the nerve is supplying, or the myelopathic symptoms, which is characterized by the spasticity in the lower limb and the bladder bowel involvement or the ataxia. So anything can happen. And if you examine these patients, then you may find some restriction of the neck movement. There may be only mild neck tenderness which is there. So based on which nerve root is involved, this is the table which shows according to the involvement of the nerve root, the involvement of the muscle, and accordingly the reflex changes in the dermatome. So what are the risk factors for the cervical spondylitis? Usually occupational trauma, aging is one of the risk factor, and those patients who have family history of neck pain or spondylosis, some patients with the congenital abnormalities, patients who are have a history of smoking, they have history of some anxiety and depression. So these patients are having risk factor for developing spondylitis. So what is required is the X-ray, epilateral view, and sometimes the oblique view is also involved. One can see for the narrowing of the joint space, there may be some sclerosis of the vertebral bodies, there may be the presence of osteophytes, and then subchondral cyst can also be present, and then one can go for MRI of the cervical spine to rule out radiculopathy and myelopathy. So these are the certain sort of differential diagnosis for cervical spondylitis, which is mentioned in the standard treatment guidelines. And what are the red flag signs? Any patient who have history of malignancy, if you suspect any infection or any traumatic event or inflammation, please refer them. So history of fever, weight loss, history of sweating, intractable pain, excruciating pain, then presence of lymphadenopathy, tenderness of the cervical spine, or presence of myelopathy and radiculopathy. So we have to refer those patients. Now coming on to the lumbar spondylosis, it is similar to the cervical spondylosis. It is also the age-related. Patients present with the lower back pain, stiffness after the period of prolonged inactivity. There may be some radiating pain, which may be radiating to the lower back or the hip region. If you examine those patients, there will be a reduced flexibility, the movement in the lower back. Also, patient may have weakness of the legs, may have difficulty in controlling the bladder, and they may have neurological bladder. So all sort of things can be present depending upon whether the simple bone is involved or the nerve root or the dura is involved. So again, the X-ray will help you in the diagnosis, which will have the similar features like thickening of the facet joint or the osteoarthritis of the facet joints, osteophytes, narrowing of the joint space. So differentials could be for the lower back. First of the important differential is the intervertebral disc prolapse, which may be acute or chronic, or there may be Cauda-Equina syndrome, which presented with the involvement of the loss of the ankle reflex and the weakness and the bladder symptoms. Also, ankylosing spondylitis, the sacroiliac joints are very close nearby of the lumbar spine, so it is one of the differentials. Then fibromyalgia, and then again we have to rule out trauma, tumor, and tuberculosis. 3T has to be ruled out in each and every cases. In each and every different condition, we have to rule out these three things. So red flag: presence of widespread weakness, loss of sensation, presence of myelopathic features, loss of bladder, lower motor neuron sign, history suggestive of cancer or infection, tender spine, history of trauma, recent history of the lower back, risk of osteoporosis, and some vascular signs and symptoms. So these patients should be referred to the higher centers. Now coming on to the fibromyalgia. So fibromyalgia is completely different kind of thing. It has some neuropsychiatric manifestations are also there. So it is characterized by widespread pain in the musculoskeletal origin and tenderness without any specific underlying cause. If you biopsy those tender points, you will not get anything. There will be no pathology, underlying pathology will be identified in that particular area. So, and this particular condition is associated with the flare-ups. And also the neuropsychological symptoms, cognitive dysfunction is common. So patient may have fatigue, unfreshening sleep, cognitive dysfunction, and anxiety and depression. So in this particular condition, the females are usually more involved. So there will be no pathological changes in the tender spots, and it is because of the disturbance in the sensory processing or because of the increased sensitivity to the pain. So this is the pathogenesis. So when to suspect any patient with a widespread pain, which can be bilateral, involving both limbs, involving neck and shoulder, muscle pain, and maybe a joint pain. Joint pain is usually rare, and then fatigue. Patient is not feeling fresh, or they have a early awakening, morning stiffness, then minor activities aggravates pain, and there will be fatigue, or some cognitive disturbances like lack of attention, and then anxiety, depression, tension headaches, migraine, and paresthesia. Also, some patients may have bladder control issues and jaw pains. So, according to the ACR criteria, we have to see for two things. One is the widespread pain scores, and another widespread pain index, and also the severity scores. And based on this, we have to include two more criteria. One is the presence of symptoms for at least 3 months, and also the other diagnoses are excluded. So, presence of WPI is based on 1 to 19 points, different points I will show you, and the severity scores based on the 1 to 12 points, and also the presence of these two, the duration and also the absence of other causes is to be included. So, this is the widespread pain index, where the right upper limb, right lower limb, left upper limb, left lower limb, and the axial system, it divides the body into certain areas, and in where we can measure the points. Also, the symptom severity, where the points are included, includes the fatigue, trouble in thinking, waking up tired, pain or cramps in the lower abdomen, depression and headache, plus these last two additional points. So, suppose this is a patient where there are 6 tender points, so the widespread pain score will be 6, and this symptom severity includes 1, 2, 3, 4, 5, 6, and 2 points here given. So, 3 points plus 1 point and 3 point, 4 point, and 4, 5, 6, 7, total 7 points. 2 points here, total 9 points. So, based on this 6 and 9, 15 points, plus this should be present. So, we can diagnose the disease. So, no X-ray, no laboratory test is required for this diagnosis, but for making the diagnosis of this disease, but to exclude other diseases, we have to go for the certain test. So, like CBC, ESR, CRP, thyroid functions, calcium profile, vitamin D, blood glucose, and serum, iron profile. These things should be done to rule out other pathologies. So, these are the differentials, because it is a widespread disease. So, any disease which involve which have a polyarticular kind of symptoms are kept as a differential diagnosis. The main one is the presence of rheumatoid arthritis, then polymyalgia rheumatica, and this polymyositis. These are the conditions. Red flag: patient with a widespread pain, hypersensitivity to the touch, muscle cramp, joint stiffness, muscle stiffness, then presence of GI disorder, bladder disorder, patient who are very anxious, they have weakness, they have depression. Such patients should be referred. Now, the last diagnosis is adhesive capsulitis. You all know it is also called as the frozen shoulder. In this condition, there will be progressive pain and stiffness and restriction of the movement, and this condition usually resolve after 18 months, but there will be some residual dysfunction of the shoulder movement. So, this condition has 3 stages, which I will tell you, and also in majority of patients in asymptomatic, or they may have mild to moderate symptoms, and according to the American Shoulder and Elbow Society, it is characterized by the functional restriction of both active and passive shoulder motion, for which the radiograph of the joint, shoulder joint, is essentially normal. So, but we have to exclude other differentials. For that, we sometimes, although it is a clinical diagnosis many a times, but we have to rule out the other diseases as well. So, there will be a loss of abduction and external rotation. So, these are the differentials. Any condition which have pain referred to or arising from the shoulder will be the differential diagnosis of the adhesive capsulitis. So, it involves the diabetics, patients with the hypothyroid, patient undergoing cardiac surgeries, patient with myocardial infarction. Onset is usually 40 to 60 years of age, and females are again involved more commonly than the male. And in quarter of patients, the disease may be bilateral, or one joint is involved. As soon as the one joint is corrected, the second joint is involved. So, any pattern can be there. If you classify the frozen shoulder, it can be primary or secondary. Primary is usually idiopathic, we don't know the cause. In secondary, the causes may be from intrinsic, their causes lying within the shoulder, like biceps tendinitis, calcific tendinitis, partial or full thickness rotator cuff tear, or some extrinsic causes like the presence of cervical spondylitis, cerebrovascular accidents, some tumors, and then arthritis of the trauma to the clavicle, scapula, or AC joint, and some systemic disease like diabetes, hyperthyroid, hypothyroid, and hyperadrenalism is the cause. So, diagnosis, how we make the diagnosis, patient will tell you that there is a spontaneous or sudden onset of severe pain, which may or may not have some trauma. Trauma is not always there, and pain which interferes with the sleep. This is an important characteristic, and if you examine those patients, then the shoulder may have some mild tenderness or restriction of both active as well as the passive movement. And the presence of loss of external rotation restriction is the pathognomonic sign for the frozen shoulder, and one has to differentiate it with the rotator cuff disease. So, 3 stages. Initially, it is very painful, where the patient requires analgesia, and then it gets frozen. Pain reduces, stiffness increases. So, in this stage, patient will have a restriction of the external rotation, and then thawing phase, where there will be no pain and there will be improvement of the shoulder function. So, these are the 3 stages: freezing, frozen, and thawing phase. If you examine those patients, you will get some mild wasting, slight tenderness, as I have already discussed. And if you do this scratch test, if it is present, then the shoulder is normal. So, the presence of a scratch test shows the shoulder is absolutely normal. Otherwise, patient will have problems. Investigation, X-rays are usually normal, except whenever there is a secondary pathologies like trauma to the AC joint, trauma to the clavicle, to the shoulder, or calcific tendinitis. So, MRI usually not done, but can be done to exclude the other diagnosis. These are the differentials. We have to think about trauma, tumor, tuberculosis, because the tuberculosis in the shoulder joint is usually a dry kind of tuberculosis, where no pus is present many a times, and it can greatly mimic with the adhesive capsulitis. So, we have to rule out the tuberculosis, trauma, and tumor Also, post-traumatic stiffness, posterior glenohumeral dislocation, rotator cuff injuries, subacromial impingements, AC joint arthrosis, cervical spine problems, and the shoulder joint arthritis. So, red flag, these patients should be assessed before initiating any treatment, and the consultation with the modern medicine should be taken. And in patients with the unexplained deformities, lymphadenopathies, palpable mass, patient with the infection, red skin, fever, systematically patient is not well, patient with history of trauma, disabling pain, significant weakness, unexplained wasting, neurological issues, patient should be referred. Treatment, early pain relief is usually needed in order to restore the function of the shoulder. We have to reassure the patients, advise for the physiotherapy. In initial stage, we advise for the intra-articular steroids as well to relieve the pain, and then give some analgesia. And sometimes the secondary causes of the periarthritis shoulder should also be treated. Thank you. I think this is all brief about those diseases. I have not told you anything which is not, related to the pathogenesis of the disease. It is all about the clinical. You just make the diagnosis, treat them according to your system of medicine, and whenever you feel that no, this patient is not responding, you just refer them. Yeah. Any questions, please?
Vitamin D is very, very low for all the people. Most of the people, when we see the vitamin D is
Yeah.
less, what is the reason?
Reason, there are several reasons, because vitamin D, low vitamin D it's a global concern. And in our Indian patients, our foods are not fortified with vitamin D. In most of the foods are not fortified, and we are not taking adequate vitamin D also. Lack of, eating, drinking milk, not taking the products which can increase your vitamin Ds, or absence of sunlight, like in north region. Many times the light is not there, so they will not able to synthesize the vitamin D. So there are several causes which can cause vitamin D deficiency, and vitamin D is a very good immunomodulator kind of thing, and in various pathology the immune system plays role. So vitamin D may be contributing factor in one of those diagnoses.
Bony island in frozen shoulder, what we can do?
Pardon?
Bony island. In X-ray we are seeing bony island.
Bony islands are silent. No, bony islands are just a benign thing. Bony island are just a benign thing. They are just incidental findings. If it is a large bony island, like more than 2 centimeter, you have to think of, yes, there could be something else. If a small bony island of less than 1 centimeter, it is presented isolated, and if there is no symptoms related to that, they are usually benign or incidental.
Sir, in diagnosis wise, can the periarthritis and adhesive capsulitis can be essentially treated to be the same, sir?
Yeah, almost. But in periarthritis shoulder, first of all, the patient will have a history of trauma. Because of that, there may be periarticular stiffness. There will be a trauma, and pain is more common in frozen shoulder than in stiffness. Stiffness patients usually have a stiff shoulder, but they have both stiffness and pain. Any other question?
Thank you,
Okay,
sir.
thank you.